Thanks very much, Larry. I'm delighted to be here, Larry. Thanks so much for having me. It's a treat to get a chance to visit with you and Marty, and I'm looking forward to seeing the program in more detail. I've sent some emissaries out here over the last few years. Howard Scher was here last year and really thoroughly enjoyed his visit with you, and the quality of the work that you've done in the field that I'm most interested in, prostate cancer, has certainly been extremely important and has changed the field in many ways. I want you all to know that I actually met your chairman snorkeling in the Red Sea many years ago when we were on a trip with the Northeastern Section meeting in Egypt. And we had a lot of fun together then, but I didn't think you would put me through this. I flew in last night, got here at 4 o'clock this morning, and after spending all day here, you're going to drag me up to the mountains and make me go down ski slopes. So it's a dangerous proposition. Since we're all friends in the field in urology together, at least I think almost all of us, I thought I would talk to you a little bit informally about some recent studies that we've been doing in prostate cancer, focusing on the general idea of where is the treatment of prostate cancer today? What are the major problems that we face? Are there patients perhaps who should not be treated, and how might we identify them? And if we do treat them, how can we assure that treatment is as effective and safe as possible? And I do this, I'll sort of go through a series of studies focusing mostly on data that we've generated at our own institution. But I welcome questions, comments, or thoughts throughout. Let's don't make it a lecture, but I can stop at any time if you have anything you'd like to add or questions you'd like to raise. So we all know that prostate cancer is the most common cancer in men in most Western countries. What's interesting about it is that the annual incidence rate has continued to rise for the last 35 years for reasons that we don't really understand. This is a logarithmic scale, and it's corrected, it's age-adjusted and corrected to the population. So this is a real tendency. This graph goes up through 97, but the data we have up through 99 or 2000 continue to show a rising age-specific incidence. This blip was when PSA first became available, and then there was a fall when a lot of the prevalent cases were detected. But the underlying rising incidence is certainly a phenomenon and probably points to something driving the incidence of prostate cancer other than the aging of the population. So there are two trends going on. Population is aging, more and more cases will be diagnosed. We're all very aggressive about biopsying patients, so we're detecting cases. But in addition to that, there's an underlying age-specific rise in incidence rate that even far precedes the PSA era. The mortality rate, fortunately, is falling, and if we go back to about 92, 93, the peak year, there's been a 25% reduction in cancer-specific mortality on an age-adjusted basis. Probably, I think, partly because of early detection and effective treatment of potentially lethal cancers, but there may be other things going on as well, maybe better treatment of advanced disease, earlier use of hormones, the development more recently of effective chemotherapy. So there are a lot of important epidemiological trends going on. But one of the constant dilemmas that we face in prostate cancer is this one that was posed by my predecessor at Memorial, Willett Whitmore, who used to always say when he was giving a talk about prostate cancer, is it possible to cure those patients when cure is really necessary, and is it necessary to cure those patients when it's really possible? Are small tumors ever potentially lethal, and can large tumors really be treated effectively, which arises from the great discrepancy between the incidence and mortality rates? I think the answer to that question is yes, it is possible, but how wide that window where we make a difference is, I'm not sure, and I'll talk about that some today. We've begun to think of prostate cancer as a series of disease states, getting a little bit away from the TNM staging system or the stage-by-stage treatment. But if you think of a patient as being, or a person, a man being in any one of these disease states, he may be at risk for having cancer, but it's never diagnosed, or he may be diagnosed with a localized tumor, and his PSA then may begin to go up after treatment. He develops metastases, he fails hormones, and he eventually dies of prostate cancer. And in any of these states, there's a competing risk of death from other causes that's much greater in the earlier phases of the disease, but as the disease advances through this state, the odds are much more likely that the patient will die of cancer. It's a helpful way to think about this, and much of the modern work we've done on the development of nomograms are really basically mathematical tools or predictive models for judging what is the transition rate from one stage to the next. What's the likelihood that a man with a localized cancer with particular features, stage grade, PSA, biopsy results, what's the likelihood over time that he will progress to a rising PSA or progress to metastases or dying of prostate cancer? And these, to the degree that we can predict this with greater and greater accuracy, we can make wiser decisions about when to treat, who to treat, and what to treat with. Certainly some of these localized cancers are indeed indolent in the sense that, as far as we can tell, they'll be there for many, many years, perhaps decades, without threatening the life or the host of the patient, but others are much more serious. We do have, finally, a phase 3 randomized trial which addresses the issue of whether treatment really alters the natural history of prostate cancer, a subject that's been debated off and on for many, many years. One study might not definitively prove the point, but certainly the results were more dramatically positive for surgical therapy than the trial founders really expected. This was a Swedish randomized trial published in the New England Journal of Medicine, and at 8 years, patients treated with surgery reduced the likelihood of developing metastases or of dying of prostate cancer by half, and you began to see the difference after about 5 years. Up to that point, there was no difference because of the pre-existing occult metastases in the two groups. One criticism of this is that at the time the study was analyzed, there was no difference in overall mortality rate, and some have argued that, well, therefore it doesn't prove anything. But I think understanding of the natural history of prostate cancer, you would be astonished if there were a difference. I didn't think there'd be a difference in cancer-specific mortality sooner than 10 years. The study will be updated in the next year or two with 12-year follow-up, and I'm sure the difference in cancer-specific mortality will continue to grow, reflecting the difference in metastatic rate, and this will show up in a difference in overall survival. But it's not a very large trial, so it's not highly powered to detect an overall difference.
One of the interesting parts of that study is that the high overall mortality rate that for patients with 20% that died
right.
7 or 8 years, which is much higher than you would expect to see in radical prostatectomy series.
Exactly, and I'll actually show you the overall mortality rate in our own series, which is much lower. The 10-year overall mortality rate was 14% in our series of 1,500, 1,700 radical prostatectomies. So I do think these men were average age 65, and they were in the Swedish health system. So this is the radical prostatectomy results from my own series of patients that began in 1983. It's a consecutive series. Every single patient that I've ever treated up to date is in this. I generated this from the computer a couple of weeks ago, and it shows the probability that a patient would remain free of a detectable PSA or free of any other treatment for cancer. If the patient had postoperative adjuvant hormones or radiation, he was considered a failure. So this is the long-term results of surgery alone as monotherapy for prostate cancer, 84% at 5 years, 78% at 10 years, and 75% at 15 years. And remember, these patients treated 15 years ago were before the PSA era. So it's not just that these were unusually favorable patients, and while I won't show you all of the statistics on what these patients were like, I was trained in oncology, and I treat every patient who comes in. I don't selectively take the favorable patients for surgery and the unfavorable patients for radiation. So I think it is a representative series that gives an idea of what's achievable with surgery. And the cancer-specific survival rate, this is now the entire Memorial Sloan-Kettering series combined with mine. So it's 4,000, I'm sorry. Let me put my glasses on so I can be accurate. This is my own series. I apologize. So this is the cancer-specific survival in these patients, and you can see at 15 years, 7 plus or minus 2% of the patients have died of their cancer. So that patients treated with surgery are very unlikely to eventually die of disease, and you can see how this cancer-specific survival rate is much better even than was reported in the Swedish randomized trial. If we look at the PSA recurrence-free probability by Gleason grade, there's really no difference in patients with Gleason grade 6 or less. They all behave very similarly. 7s are intermediate, and 8, 9s, and 10s are much worse. But I put this up to remind you that a patient with a high-grade cancer on biopsy is not incurable. Half of these patients, roughly, at 5 years, and a third of them at 10 years remain free of cancer, no other treatment than surgery alone. So it is quite possible, even though there are many failures up front, it's quite possible to control even the most high-grade cancers. And if you find a very high-grade cancer when it's still confined to the prostate, which roughly half of these are nowadays, then the long-term disease-free survival is excellent, well above 90%. So that's always made me feel that you can interrupt the natural history of even aggressive prostate cancers with if you remove them before they extend outside of the prostate. This is by pathologic stage of the disease, and just several points to make here that those patients with cancers confined to the prostate do indeed do very well. Only about 10% of them will ever relapse, but being confined to the prostate doesn't guarantee that your cancer will be cured. There are some patients who develop recurrence and metastases even though they have a tumor confined to the prostate. But if we look at some patients, for example, those with seminal vesicle invasion at 10 years, patients with seminal vesicle invasion but negative nodes, about a third of them live free of any recurrence or any other treatment. So that raises a concern in my mind when people begin to say you don't need to remove the seminal vesicles. Even though the incidence of seminal vesicle invasion documented histologically is low, still these patients do have curable cancers. Some of them do, and I think that leaving the seminal vesicles in is unnecessary and also risks not curing these patients. But look at these patients with positive nodes. These are all histologically positive nodes confirmed by Tom Wheeler, who was a pathologist at Baylor, or Victor Reuter at Memorial Sloan-Kettering. About 15% of these patients seem not to recur. Similar data recently from Johns Hopkins, from the Cleveland Clinic, and we're putting together a large series. But I think that the dogma that I've written, too, that once prostate cancer spreads to the lymph nodes, it's no longer curable or it's tantamount to metastatic disease, may not be true. And the long-term course of that cancer, just like we've learned with bladder cancer, may depend somewhat on the nature of the primary tumor. If you have a high-grade, locally extensive tumor with positive nodes, you'll do very poorly. But some smaller, better differentiated tumors do go to the nodes, and apparently some of those patients anyway with surgery alone, no other treatment, will survive long-term with an undetectable PSA.
Would you take that one step further a la Studer and say that an extended lymphadenectomy is indicated in this higher risk patient?
I must say, Larry, I do it in every single case, and I've done it since I was a resident with Don Skinner. That's the node dissection that a standard node dissection for me has always been to remove all of the lymph node-bearing tissue between the bifurcation of the iliac vessels all the way down to the sciatic nerve from pelvic sidewall to bladder. And so what Studer described, which he also saw when he was a fellow at UCLA, is a standard node dissection. And I just, if you remove that little pocket of nodes just above the nerve and the distal half of the triangle, which is what I think everybody in America, in the States do, you're going to miss, if Studer's numbers are correct, you'll miss, 60 to 65% of the positive nodes. And I think that's true. Now, I know that Jay Smith wrote a paper saying they didn't find it, but that was a very small study. I don't think that disproves it.
15% is an extended lymphadenectomy.
Yeah, which I call a standard lymphadenectomy as opposed to a limited.
I thought he said that all the way up to the bifurcation of the aorta.
No, it's only to the bifurcation of the iliac vessels. It's just between below the iliac vein, distal to the hypogastric vein, and surrounding the obturator nerve above and below it. Marty?
The seminal vesicle
spread goes systematically along the seminal vesicle. Do you take the seminal vesicle all the way to the tip? Or
yeah, I do, but again, of course, the base is going to have most of it. But one of the reasons why a number of years ago, Tom Wheeler and I at Baylor published a series of seminal vesicle invasions showing there were three types. It can extend up the ejaculatory ducts into the seminal vesicle, sort of from the lumen side. It can grow out of the prostate like extracapsular extension and then back into the seminal vesicle, sort of crab-like, invading the seminal vesicles. Or you can have satellite metastases like melanoma. You have a primary tumor in the prostate and a completely separate small nodule of tumor in the seminal vesicles. When you have that, the prognosis is excellent. It's very good. And those you wouldn't see unless you section the seminal vesicles, more than once. You'll miss most of those. But that's about 20% of all seminal vesicle invasions. So yes, I do tend to take them all out. I don't see any good evidence to support the current ideas in Europe that taking out the seminal vesicles leads to incontinence and impotence. I think it's really a matter of if you respect the anatomy, there's no reason you should damage the nerves there. I think they're at much greater risk somewhere else. But if you use a lot of cautery and things, you certainly can damage them. But normally it shouldn't be a problem. This is another interesting thing. So this is 15-year cancer-specific survival for each of these pathologic stages, and I show this to our own residents and fellows. Look at the patients with positive nodes. Their 10 or 15-year cancer-specific survival is really quite good, 70% at 15 years for patients with positive nodes. It's another reason why we stopped doing frozen sections and abandoning the operation just because the nodes were positive, because these patients have a very long survival, and even if they ultimately recur, which most of them will, the quality of life, we believe, is better with the primary tumor out, and they don't need radiation to the primary tumor or earlier hormones, so they can go for a longer period of time with no other treatment. So once we're in the operating room nowadays, I think we would just virtually never stop the operation, and we don't do frozen sections. So I think all of that amounts to the idea that treatment does interrupt the natural history of the disease, but it still leaves many important questions open, which is who needs to be treated? Does everyone? Isn't there still a role for watchful waiting in some patients? How do we decide surgery, radiation, seeds, combinations? How can we deliver the treatment optimally, maximum benefit with lowest risk? And then I'll show you some data about what happens next. What about if the PSA begins to rise after surgery? So let me just run through a little bit about this. We have a paper that's coming out soon, or is out in this month's Journal of Urology, on our experience with watchful waiting. And I do believe that there is a role, maybe not for watchful waiting in the traditional Scandinavian sense of go home and call me if your metastases ever start hurting, but I think in the sense that you don't necessarily need to treat everybody when you meet them, when you first diagnose them. It might be reasonable to wait, watch the disease, sometimes to consider a biopsy, particularly a biopsy showing a relatively focal tumor, as a warning sign that you might develop a potentially lethal disease, but you don't necessarily have one now, and see what happens as the disease evolves and treat those patients who have evidence of progression. And I think that's the kind of thing that we badly need clinical trials to look at. And can we identify indolent cancers, very small tumors that are well or moderately differentiated and are confined to the prostate, that have extremely low likelihood of altering the patient's life, at least in the next 10 or 15 years. So we know this phenomenon is true. We know from epidemiological data that for every man who develops a histological cancer in the prostate, only about a third will be diagnosed with a clinical cancer. Most of these we never find, and only 8 or 9 men are at risk of dying of prostate cancer. Clearly we want to interrupt this, and we'd like to reduce morbidity from this, but we don't want to treat every single histologic cancer as if it's a life-threatening disease. And with increasing screening of our populations, the stage of the disease is migrating upward. Nowadays, at our own institution, nearly 85% of patients have a tumor that's confined to the prostate. Lymph node metastases and seminal vesicle invasion are rare, and the disease continues to shift to a more and more favorable version. This is a series of patients where We measured the volume of tumor in every case, and the red bar is the median volume by year for these patients. And you can see a steady decline in the median volume that's approaching half a gram as a median size of the tumor. The yellow dots are those tumors that are less than half a gram, no high-grade tumor, and completely confined to the prostate. So they would fit the classic definition of an autopsy or histologic or incidental or indolent cancer, and that percentage is now running around 25 to 30% of all the patients that we see nowadays, and it's increasing. This is a typical clinical cancer. This is what we would have considered an early-stage prostate cancer 15 years ago, a small palpable nodule, but it's got multiple different Gleason grades in it. It's invading and extending through the capsule very close to the margin of the tumor. And this is a typical indolent cancer that we removed. This is a radical prostatectomy in a patient who actually had a palpable nodule on this side, but there was no cancer there. The biopsy was incidentally positive over here, and this is truly a small tumor.
Can you comment whether these were multifocal or they look like they're unifocal from the map.
Some are. This is probably a multifocal tumor, and most prostate cancers are multifocal. This looks like it has a separate focus over here. This one either is confluent or is a single focus. But on average, we see about 5 tumors per prostate. If you meet the definition of an indolent cancer, I've never had a single patient who's ever recurred. And this is 126 patients when we put this together nearly 10 years ago, and we're updating that now. But I looked in the computer recently, and if you're under 0.5 grams, no poorly differentiated component, and you're confined to the prostate, not a single patient ever has a rising PSA postoperatively, indicating at least that that is not a form of prostate cancer that metastasizes. Now, whether it will eventually grow and do that, I can't tell, but if it's removed, it's 100%.
PSA criteria for making a diagnosis of indolent prostate cancer?
No, but I'll get to that, because it's much easier to make the diagnosis once the prostate's out. The trick is, can you do it before that? So let's just look at the results of our own expectant management program. So we know that if we look at Peter Albertson's famous study in JAMA, that even patients with Gleason 6 tumors have a significant risk of dying of prostate cancer over time if they're managed initially conservatively. So using grade alone is not an adequate criteria to say this is not a dangerous tumor. We need better data than that. So some years ago, I began to follow patients who had what appeared to me to be favorable tumors in this way. If they wanted to go into a deferred management program, I followed them with DRE and PSA every 3 months, and then I always repeated the biopsy within 6 months of their initial biopsy, and then did it about a year and a half, 2 years later, and at 5 years, if everything else appeared the same. If there was evidence of change, then I'd biopsy them more often, and I would operate on them or treat them if they had clear evidence that the tumor was progressing. It was a favorable group. A small number of patients had a Gleason 7 tumor, but most of these 88 patients had a favorable tumor. And I sort of developed a point system over the years for what do I mean by progression. And progression meant at least 3 points. That is, a change in PSA velocity greater than 0.75 a year, consistently over 2 years, any Gleason pattern 4 or 5 cancer, more than 3 cores positive, or a new lesion that developed proven by biopsy. But you could also get 3 points by some combination of 2 and 1 point. So if they got to 3 points, we considered that progression and treated them. And here's the probability over time that the tumor would progress, and here's the probability that the patient would be treated. So some patients wanted treatment without evidence of progression. But you can see that at 5 years, roughly 2/3 of the patients have not progressed. By 10 years, although there's not a whole lot of patients out here, about half the patients have not shown evidence of progression, but you can see about 2/3 of them have gone on and been treated over time because of their own worry about it or underlying fluctuations in PSA. Generally, the reason for going on and treating patients were related to biopsy, increasing number of cores, higher grade tumor. Occasionally it was PSA, and occasionally it was a new lesion, palpable or visible, but most of the time it was biopsy criteria. Just like the Toronto group, PSA doubling time was not reliable. In fact, most patients had a negative doubling time. They end up getting diagnosed when their PSA, which is fluctuating, is high, and then they come in and they get treated and their PSA regresses to the mean over time. Only 10% of the patients had a doubling time less than 2 years. So doubling time is really not a very good criteria.
How do you, using your teaching slide, how do you control for the drift in lesion grade?
Well, yeah, I can't say whether in some cases we were probably finding a higher grade tumor that was already there that we had missed. In other cases, it might have developed new. I can only say, Marty, that most of these patients not only had their diagnostic biopsy, but had a second biopsy. So they had 2 sets of biopsies to get in the study. So we did pretty good sampling. It wasn't just that a patient would come in with 4 cores from outside and I'd put him in the study. We always did our own biopsy if he hadn't been biopsied twice from outside, almost always. When I looked at what predicted progression, there was none of the things that changed over time predicted progression. The second biopsy did. If there was cancer in the second biopsy, the baseline PSA, the baseline PSA density. And that's not too different from the studies that have been reported. But this is what struck me is that if the repeat biopsy was negative, very few of the patients showed progression. If the repeat biopsy showed any cancer, progression was almost consistent in those patients. So that turned out to be the most reliable criteria. And we subsequently did a study at Memorial. This is a group of patients who had a repeat biopsy by us and then went on to have a radical prostatectomy anyway. And that 14 had a negative repeat biopsy and 45 it was positive. And look at the difference in the size of the cancer. There were none of these patients who had high-grade cancer. 71% of them fit the criteria for indolent cancer. When the second biopsy showed any cancer, they very rarely fit the definition. They were much larger, and about a third of them were not confined to the prostate. So I think this is at least a lead point as to how do you select patients who may have a favorable tumor.
When you do your second biopsy, do you focus on the area where the primary was originally, or just random options?
Well, we typically now do 14 cores, but if there's a visible or palpable lesion, we'll take additional cores from that.
But the original biopsy was right base, you don't go and take every cores from that area?
No, we've just gone and done, we take 2 from the right base because we do lateral and medial PZ biopsy.
Yeah, knock out 4 people and you do it.
Very gentle touch. So Val Carter's study from Hopkins also found that although they didn't make a big deal of it in their paper, a second biopsy was highly predictive of progression. PSA density and free PSA were also somewhat predictive. And in the study from Toronto, the progression rate over this curve looks exactly like ours. It's just only out to 5 years, and we've got some patients now out to 14 years. So, but it looks like it's following very similar actuarial trends in the probability of progression, even though they use a little bit different criteria. Here's what happened to the patients. So this is the patients who had met the definition of progression. Here's how they were treated. Some patients got treated with progression that didn't really meet the full criteria, and some just because of anxiety. So you can see 18 patients were treated with radical prostatectomy, 9 with radiotherapy, 1 with hormones, and 13 patients have had no treatment in spite of some evidence of progression. And this just summarizes where we are with this. At 5 years, 36% of the patients had progressed, 44% were treated. Of 19% of the patients treated for progression, but none treated without progression have failed therapy. That's any kind of therapy. In fact, all 3 of those failures were with patients treated with radiation. None of the 18 patients treated with radical prostatectomy have evidence of progression yet, although the follow-up is certainly not long. So at least as a tentative idea, I think this is strong enough data with the other papers that have been reported that large clinical trials, I think, are justified to really look at a policy of deferred management in some patients. These are generally the indications: low-risk cancer, short life expectancy, or willing to accept some risk of metastases. And these are the clear contraindications to that. And the advantages are obvious that the patient will avoid the side effects of therapy. There's a lot of disadvantages, and the more you think about it, the more the anxiety of living with a cancer you know you have is wears on patients and measurably affects quality of life if you use a quality of life index. So can we identify indolent cancers? Well, I think that one problem we've had conceptually is the idea that how many papers are there in the literature saying, well, I had a lot of patients that were low Gleason score. I had patients that had only a single biopsy positive or only 3 millimeters of cancer, and look, a lot of them had a bad cancer. I mean, I think we've made the point, no one criteria can identify a favorable cancer, and if you look at clinical stage, these are the percent of patients who turned out to have an indolent cancer by the pathological criteria. So clinical stage can't do it, biopsy Gleason score can't do it, preoperative PSA, even if your PSA was between 0 and 1, only 50% of the patients had an indolent cancer. PSA density alone can't do it. Total cancer length less than 1 millimeter. Half the patients do not have an indolent cancer. Percent positive core is percent cancer. No one criteria can do it, and so you really need a nomogram, or you need to combine the criteria together in some model to say if you meet all of these criteria. In this case, we've got your PSA, clinical stage, biopsy Gleason grade, the size of your prostate, because the larger the prostate, the greater the likelihood your cancer is favorable. Prostate volume is clearly a favorable, an important criteria. The millimeters of cancer in all your biopsy cores and the millimeters of non-cancer, and this sums up all the biopsies you've ever had. So whether you've had 1, 2, or 3 biopsies, we put them all together on here. Then you get a certain number of points, and you can predict the likelihood that this is an indolent cancer. Now, you just can't get to 99% with this. So it's not going to be certain based upon the level of data we have. And you can see we've dropped patients out of this if they have a PSA greater than 20, any high-grade cancer, T2B or greater, more than 20 millimeters of cancer. We just a priori say you don't have an indolent cancer. So that's the best we can do today. We need better biopsy or better imaging methods if we're going to do better. And this clearly is better on an ROC curve. This is more accurate than using stage grade and PSA alone, much less using any one criteria. So I think biopsy results can help us, but we're still not going to get absolutely reliable criteria, and that's where I think following patients over time and intervening if you need to. So what about which treatment? If we now say this is a patient who needs treatment, we have a bewildering array of options, and I don't have any easy way to say, except that if you think about each of these, there are specific advantages and disadvantages, indications and contraindications for each, and I'm not going to go through those because it's a boring list and you all know it. But I will say the point I wanted to make is that choosing treatment and applying that treatment is something that should be highly individualized. The best treatment of prostate cancer today requires adapting the therapy to the particular nature of the cancer in the particular individual and not having one operation for all. I went to the operating room once as a visiting professor at a very famous institution that does thousands of radical prostatectomies, and I was helping the resident do the case, and as we were getting started, I said, well, tell me about the patient. And I said, how old is he? And he sort of looked around and asked the anesthesiologist, how old is this patient? And I said, well, what was his PSA? He said, well, I think it was under 10. He asked the junior resident, what was the PSA? And I said, well, what did his biopsy show? Well, it was a Gleason 3+3. Well, how many cores were positive? Where were they? Well, we just take all the biopsies and drop them in a cup, and we don't really do that. You either have cancer or you don't. That's okay. And then we do the same operation every day. Every patient we operate on, and it either cures you or it doesn't. The rest is up to the good Lord. I think that is not the standard of care today. That might have been okay 10 or 15 or 20 years ago, but with modern systematic biopsies that we have, with quantitative biopsy information, with serial PSAs, we can do much better in determining what does this patient have and how do I need to modify my treatment, whether it's seeds, external beam, or surgery, to be sure that I get the best possible chance of cure with the least risk of side effects. And choosing a treatment depends upon all of these factors. The patient's life expectancy, the particular nature of his cancer, how likely it is to metastasize or result in his death, how effective is the treatment and the risk of treatment in your hands. Not what it says in the textbook, but how likely are you to harm the patient or benefit the patient, and what does the patient feel about this? How worried is the patient about living with cancer, being impotent, having incontinence, having a bowel problem from treatment, and then making a decision gets to be a very complex, subtle factor that is hard to do. I think the nomograms we use do help. This is the very familiar Parton tables. As you all know, you look at the PSA, the clinical stage, the Gleason grade, and you come up with what are the chances that the tumor is organ confined. But that is not the chances that the cancer is curable. That's just a pathological stage that you're guessing at. And this has been misused by people as famous as Andy Grove, who, if you read that article in Fortune magazine, he said, I looked at these tables, I only had a 35% chance that my cancer was organ confined, therefore I did not want surgery because with that little chance of cure it wasn't worth it. I mean, that's a complete misunderstanding of the tables. Everybody who's organ confined is not cured, and many people who are not organ confined are cured. So you need a way of deciding what are the chances that your cancer will be cured, or at least cure. The definition of cure here is 5 years free of any evidence of progression or of any other treatment for cancer. And I think you all are all familiar with this nomogram. Again, you assign points for each value on each bar. You read the points and you say this particular patient has a 47% chance of 5-year freedom from recurrence. But if you look at the Parton tables, he only has a 21% chance of organ-confined cancer. There's consistently a big difference between these two numbers in many patients. And of course, we use these on the computer, on pilots, or it's available on the website. If anybody wants to download these, you can get the software from there. But if you look at the 5-year freedom from recurrence, it's always much greater than the chances the tumor is organ confined because we can cure some patients whose tumor is not organ confined. Let me just get through that safety. So, having said that, at least those tools help in some way to quantify the risk for the patient. How likely is this operation to be beneficial for you? We're a long way from having fully robust decision analysis models with all of the pros and cons in them. But let's look at the issue of optimal delivery of therapy, because I think the key point I want to make here is that the choice of treatment is important, but the way the treatment is planned and delivered may be more important. It may be better to get very well done seeds than a mediocre operation. Even if in the best of hands, the long-term results might be better with one or the other. So what's available in your community, what's accessible, and what's done in an extremely high-quality way may make a difference. That's where the environmental factors may come into making a reasonable decision. And just as a couple of examples of this, look at the data with external beam radiotherapy by just simply adjusting the dose in unfavorable risk patients. This is the Memorial Sloan-Kettering data. You can markedly alter the PSA progression-free probability by increasing the dose to 81 gray. And if you look at the biopsy results, there's a very nice relationship between the dose delivered and the chances of achieving a negative biopsy with radiation. So dose matters. You could add hormones into this too. There's some patients who do better with hormones. The same thing's true with surgery, though, and I don't think we as urologists have been willing to accept the fact that how the operation is done has a huge impact on the results of the operation. We looked at this in the Medicare database a couple of years ago and showed that if you divide surgeons, here we had 1,000 surgeons, almost 11,000 patients, and we divided them into 4 quartiles of patients: low-volume surgeons, medium-high, and very high-volume surgeons. Notice that 159 surgeons, about 16% of the surgeons did half the cases. And we showed that there was no difference in perioperative mortality, but there was a significant drop in perioperative morbidity, a decrease in urethral strictures, and a decrease in incontinence with high-volume surgeons. That was statistically significant across the board. So this is sort of a gross take at a population-based study suggesting that there was a volume relationship, that experienced surgeons are generally doing a better job of perioperative complications. But what was, I thought, more intriguing in this was that if you took these 159 busy surgeons and you took one outcome, for example, urethral strictures postoperatively, this was the mean and this was a random distribution across the mean. That's what you would expect it if you went and looked at the stricture rate among these 159 surgeons. But this is what we actually saw. There were some surgeons with a stricture rate way out here, above 50%, and there were some surgeons, quite a few, 19 surgeons, with a very low stricture rate where we would have expected 1. So a tremendous difference in outcome even among those busiest surgeons, and the same thing was true for perioperative morbidity and for urinary incontinence. And if we looked at this, when I saw that data, I said, wait a minute, is this some kind of coding error that we're picking up from the database? But when you looked at the results, the surgeons who fell into the poor category on perioperative complications also were much more likely to have poor results with urethral strictures, poor results with incontinence, and vice versa. There was a significant relationship among those. So at least it made me say, when people say, well, who should I go to for my radical prostatectomy? I say, well, I don't know what many doctors' long-term continence and potency results are. They're hard to measure. But if you look at how their patients do in the hospital, that's probably a good indication of how the patients are going to do otherwise, at least until we have better data. So we also looked at this in other ways. This is positive surgical margins. If we use that as one result, how well are you doing? What is your rate of positive surgical margins? We looked at that at Baylor a few years ago, almost 2,000 patients, all cases looked at by one single pathologist using the same criteria for everybody. Nobody got neoadjuvant hormones, and the overall rate of positive margins was just under 16%, but it ranged from 0 to 71% among these 31 different surgeons. Even if we took surgeons with at least 10 cases, it ranged fourfold. So we published a paper last year looking at this in the whole group of Baylor and Memorial Sloan-Kettering, 44 surgeons. We very carefully corrected the positive margin rate by the burden of disease, by PSA, Gleason grade, and extracapsular extension, seminal vesical invasion, and we found that the surgeon was an independent risk factor for a positive margin, even when you included all of the pathological features and clinical features of the tumor. So how we do the operation is directly affecting. It's not just that I'm selecting good cases and you're selecting bad cases. When we even it out, we see that there's a difference among surgeons. This is my own results over time showing a trend towards a decreasing surgical margin rate, although there's an increasing percent organ-confined cancers. When we looked at these two factors, this year of surgery, that is, the surgical technique, was a significant independent factor in decreasing margin. So even one surgeon can decrease his margin rate over time by careful attention to detail. And we looked at this. We have a paper coming out this year looking at surgeon as an independent risk factor for a PSA recurrence, even when you correct for margins. So even when you correct for positive surgical margins, the surgeon is an independent risk factor. So there's things we're doing in the operating room, and I don't know that we can identify them right now, but there are things we're doing that means that one patient's more likely to recur and the patient operated on by another doctor is less likely. That doesn't necessarily mean that, I'm doing it right and you're doing it wrong. What it means is what we're doing matters, and we need to study it and look at it and hope that the young people who are training today will realize we don't have it right yet, and will think through what can we do to teach everybody how to improve the general results of this. So until you recognize there's a problem, it's hard to come up with a solution. All right, just a couple of minutes on some new data on rising PSA after radical prostatectomy. So the operation doesn't always work. Sometimes the cancer comes back, the PSA begins to rise. Who do you give hormones to? Who do you irradiate, and when? So Andrew Stevenson, who's a graduate of the McGill program, one of our fellows, an AFUD scholar, has done what I think is an extremely elegant study. I'll just show you a few slides of it, predicting the outcome of salvage radiotherapy for patients with rising PSA after radical prostatectomy. So he collected, along with Kevin Slawin at Baylor and Mike Catan, collected a group of 537 patients who were treated with radiation for a rising PSA after surgery, and from 5 different institutions. And that paper is coming out in JAMA this month. And here was the probability that they would remain free of PSA. They would have a complete response to radiation. 66% had their PSA went to undetectable with radiation. Only about 20% of those patients got hormones with radiation. And this is the probability that their PSA would remain low or undetectable over time. You can see the 3-year probability was almost 50%. The 7-year probability is out here at around 35%. Here are the risk factors for responding to radiation. The higher your PSA level was at the time you got radiation, the greater the likelihood that you would recur. And when we looked at the analysis at patients who were radiated below 0.6, they were even more favorable. So the higher the PSA, the greater the likelihood of recurrence. And if you get radiation when your PSA is over 2, almost nobody has a long-term response. Patients with negative margins are more likely to recur than those with positive margins. If a PSA doubling time is short, they're more likely to recur, and if they have high-grade cancer, they're more likely to recur. So those aren't surprising, but it was interesting that none of the other pathological criteria were important. It was the margin status that was most important, along with Gleason grade. What was interesting is that many patients with poor prognostic features achieved a durable response to radiation. 30% of patients with Gleason 8 through 10 tumors in the radical prostatectomy specimen, 42% of patients with a short doubling time, less than 10 months, 40% of patients whose PSA never became normal after surgery had a durable response to radiation, and 46% of those whose PSA began to rise within the first year. All criteria we would have said suggest metastatic recurrence rather than local recurrence. Of all patients who had a long-term response, 63% had a PSA rise within a year of surgery, 45% had a short doubling time, 20% had high-grade tumors. So however you look at it, we're seeing some patients who respond well to radiation who have what look like high-risk tumors from metastatic disease. And this is a table. If you look at the patients with high-grade cancers, the overall response rate, the overall 3-year progression-free survival was only 31%. But if they had a PSA under 2, it was a little bit better than over 2. If they also had a positive margin, half of them responded. And if they had a long PSA doubling time, 89% did. So just because someone has one adverse factor, or even 2, does not mean that they don't have local recurrence. We've probably put too much weight on that. And again, here's a nomogram using all of these criteria that we now use actively to predict should a patient get irradiated. And I've irradiated several men recently with seminal vesicle invasion that I probably would not have otherwise because overall they turned out to have a 60-70% likelihood of responding. All this makes me think that local recurrence may be a bigger problem than we've realized, although Walsh's series generally reports only 2 to 8% local recurrence. It's grossly underdetected. We don't have a good way of screening for it. In the Swedish randomized trial, at 8 years, 19% of patients in the surgery group had biopsy-proven local recurrence. 19%. The 3-year progression-free probability for early salvage was 50%, and the complete response rate was 66%. So all of those things make me think that it may be beneficial. Finally, just a note about rising PSA. Whether you get radiated or not, if you get a rising PSA, we all wonder what happens to you over time. And I want to introduce this idea of the PSA castrate disease state. Many patients, when they have a rising PSA, don't wait around like in the Pound study from Hopkins, where they waited to develop metastases before they started hormones. Most people get hormones now, and the natural history of rising PSA treated with hormones is not very well documented. We don't really know how long they respond and what happens to them next. So let me show you some new data about that. If this is the overall freedom from recurrence by PSA after surgery, 76% at 15 years. If that's the starting point in 4,000 patients, we have 170 who've died of cancer. If you remember the Pound study from Johns Hopkins, Pat Walsh's patients, nearly 2,000 patients, 315 had recurred. None of them were treated with hormones. 103 had developed metastases. The median time from a rising PSA to METs was 8 years, and the median time from METs to death was 5 years. So we've all thought in terms of about a 13-year survival for men with a rising PSA. But if you look at this, this is the probability of dying of other cause or dying of cancer for men from the time that their PSA first becomes elevated. So this is the probability of dying of cancer. You can see at 15 years, about 46% of these patients have died of their cancer. In other words, the median chance of dying of cancer after your PSA begins to rise is more than 15 years. So these patients have a long cancer-specific survival. The second thing was, what about hormonal treatment? Well, most of these patients get hormone therapy before they develop METs. This is the probability that the patient will be put on hormone therapy from the time that the PSA begins to rise. So you can see the median time was 3.4 years. So the average patient has watched about 3.5 years, but still, even out here at 10 or 15 years, some 20 to 30% of the patients have still not been put on hormones. They're still being followed with a rising PSA. If we look at how long do you respond to hormone therapy if your PSA, if you're put on hormone therapy for a rising PSA, the median time of response is 10.8 years. So hormones really work for a very long time, and out here at 15 years, we still have 30% of the patients who are still responding to hormones. So this is why we worry about starting hormones early, because they do work, and they work for a very long period of time. So these patients are at risk of the side effects of androgen deprivation therapy for a long time. And this is perhaps the most striking slide to me was, once your PSA begins to rise again, even though you don't have metastases, once your PSA begins to rise again when you're on hormones, you really are in deep trouble. The median survival from the time your PSA begins to rise is only 25 months. And no patient lived to 5 years so far in this study. There are 86 patients in this group, 85 patients. 20 of them had metastases at the time they started on hormones, but 65 did not. And the survival rate was equally bad whether the patients actually had metastases or did not. And the median time is only about 2 years, and nobody lives 5 years. So suggesting that once your PSA begins to rise, you're in deep trouble. And for that reason, we've begun to think about this new disease state that probably is more common than this way. Most patients get hormones, have a rising PSA, and then eventually die of their cancer. So with that, I'll stop. I've already into information overload here. And I appreciate very much your attention, and I'm delighted to get a chance to be here with you today. If we have a minute or two for any questions or comments, I'd be glad to do my best. Thanks. Okay.
Peter, just a couple of questions. How would you factor in the observation that a lot of patients with seemingly localized disease actually have evidence of circulating cancer cells, either in the blood or in the bone marrow, up, say, to 70%, shows our PSA positive epithelial cells and bone marrow biopsy. Would you factor that into your...
Sure. I think it may, even as we get better at those assays, it may be more and more of those men actually have circulating cells. But obviously, as Paul Lang and others have shown, sometimes they disappear over time. Sometimes they remain there, but the patient's PSA remains undetectable. So I don't know what to make of those cells, what the biological significance is. At least as a prognostic factor, it's hard for us to either quantitate the number of cells or to characterize them to say which ones are truly indicative of the development of metastases and which are not. But Nick, I think we've known that solid tumors shed cells into the circulation very commonly. It's not a new phenomenon with prostate, but we've got to figure out a way to interpret what it means.
One other question quickly. With regard to the technical aspects of radical prostatectomy, And knowing now that when you create a wound, you get all sorts of growth factors arriving at the scene of the wound, would you not expect that somehow wound creation may be an adverse risk factor in itself? The question is, with smaller wounds, would you expect that the outcomes be altered in some patients?
Right. Well, very well worth studying. I mean, I worry about seeding in the wound too. We did a study a number of years ago, about 10 years ago, where we actually looked at the PSA level in wound fluid right after the prostate was removed, and it's very high. It's 20,000, 30,000. And if you irrigate, you can irrigate it down to about 50, 60, but you can't get it back down to serum levels, suggesting that you are spilling seminal fluid and undoubtedly prostatic epithelial cells, and in high-grade cancers you may be locally seeding the area. So that could be one factor, and if you can do the operation in a way that's less manipulative of the prostate, it might make a difference. I mean, we don't see wound seeding in the sense of the abdominal wound. That's almost unheard of. But whether there's seeding in the bed, I think is quite possible now.
What about with laparoscopic techniques now? Will that reduce the size of the wound or not?
I mean, it might change the way the prostate's manipulated, but I don't know. I think it's worth measuring.
Do you have a question? One more, last question.
Do you video yourself to improve your technique?
Yeah, I pretty much video every case and look back on it when the patients do poorly or well. We look back and try to understand why.
Okay, well, time's up, and that was truly wonderful. Thank you.
Thanks for having me.